Today, we will be learning about cardiovascular tests and procedures that are often used in the diagnosis of diseases and conditions such as coronary artery disease, arrhythmias, and acute myocardial infarction. Objective data obtained in these diagnostic tests and procedures can often guide our decisions in how to best care for our patients. The basic tests we will study fall into the following categories. 1. Heart rhythm abnormality tests such as Holter monitoring, ECGs, and electrophysiologic studies, EPS mapping. 2. Tests for ischemia, including resting and exercise ECGs, pharmacological stress testing, single photon emission computed tomography, SPECT, positron emission tomography, PET, ergonovin challenges, echocardiography, cardiac catheterization, MRI of the heart, and in digital subtraction angiography. 3. Tests for heart valve integrity, including echocardiography with and without contrast, and cardiac catheterization. 4. Tests for ventricular size and ejection fraction, including chest X-rays, multigated acquisition or angiogram, MUGA imaging, and echocardiography. 5. Cardiac muscle pump functioning tests, including MUGA, echocardiography, ventriculography, and digital subtraction angiography. 6. Tests for acute myocardial infarction, including cardiac enzymes and markers and resting ECG. And lastly, 7. Vascular diagnostic testing, such as ankle brachial index, segmental limb pressures, pulse volume recordings, and arterial duplex ultrasonography, which uses both Doppler and ultrasound to image blood vessels. Let's look at some of the enzymes and biomarkers that can give us a clue to cardiac injury. When cardiac muscle is damaged, it releases enzymes into the bloodstream, which include creatinine phosphokinase, CPK-MB isoenzyme, troponin, myoglobin, carbonic anhydrase 2, and cardiac myosin light chains. Since CPK can be elevated with other tissue injuries such as skeletal muscle and brain tissue and after cardiac surgery and CPR and thrombolytic treatments, the gold standard for myocardial injury is currently troponin levels. Elevated troponin levels may also occur in heart failure and renal insufficiency, so troponins alone may not be specific to MI. The ratio of myoglobin to carbonic anhydrase 3 is currently being evaluated as a diagnostic tool. In skeletal muscle injuries, this ratio stays constant, but in acute MI, this ratio changes within 2 to 15 hours and may be more beneficial than either CPK or troponins. Other tests include blood lipids such as total cholesterol, high-density lipoproteins or HDL, and low-density lipoproteins or LDL, used to assess risk factors for coronary artery disease, CAD. Homocysteine and C-reactive proteins that are also elevated in patients to develop heart disease, and hematologic tests that have also been associated with increased risk for developing coronary artery disease, such as increased fibrinogen and elevated white blood cell counts. Newer markers that are being looked at are lipoprotein A, LPA, oxidized LDL, and infective agents such as chlamydia pneumonia as risk factors for CAD development. Other potential clinical laboratory risk factors for CAD include B-type natriuretic peptide, BNP, which is elevated in heart and renal failure. Normal ranges for BNP are 8 to 23 milligrams per deciliter. It is the gold standard for diagnosing heart failure. Since BNP is not suitable as a single measure for renal disease, we will look at creatinine levels to make a definitive diagnosis. Normal values for creatinine are less than 1.5 milligrams per deciliter, and elevated levels are indicative of renal disease, with values above 4 milligrams per deciliter indicating severe renal insufficiency or failure. The last laboratory test of value to the RRT is serum glucose. Levels above 110 milligrams per 100 milliliters in a fasting patient may indicate a prediabetic or diabetic state, and is often associated with a 2 to 4 times greater risk for developing cardiovascular disease if not properly managed. Non-invasive tests that are used for assessing the heart include Holter monitoring, echocardiography with or without contrast, imaging techniques such as PET and CT scans, SPECT and electron beam computed tomography, MUGA, MRA, and MRI, and minimally invasive techniques such as TEE. Holter monitoring consists of a patient wearing a small ECG monitor for 24 hours of continuous monitoring to evaluate the possibility of cardiac arrhythmias and symptoms. If a patient demonstrates a life-threatening arrhythmia, they are referred to electrophysiological mapping studies, EPS, particularly if they have VTEC. Echocardiography uses pulse-reflected ultrasound to evaluate the functioning of the heart, particularly the valves, integrity of the intraatrial and intraventricular septa, size of the ventricles, and how fast the heart is beating and how much volume is ejected from the left ventricle to estimate stroke volume and ejection fraction. It can be used to diagnose such things as pericardial effusions, cardiomyopathies, mitral and aortic valve insufficiencies such as prolapse, stenosis, and regurgitation, pericarditis, congenital heart defects, and aortic dissections. Because there are issues with image quality in a standard echocardiography called a TTE, using a probe inserted into the esophagus to view the heart improves the view of the heart and mediastinum. This is known as TEE, for transesophageal echocardiography. The probe is swallowed like food after the patient is sedated and anesthetized, but awake. The TEE allows for improved visualization of structures and is useful in the detection of blood clots, masses, and tumors within the heart, and is the modality of choice when evaluating known or suspected cardioembolic stroke. When contrast is added to either a TTE or TEE, it allows for more accuracy in assessing myocardial perfusion and ventricular chambers. It can be used for quantifying cardiac perfusion and is useful when assessing areas of myocardial damage with or without collateral blood flow and evaluating the effectiveness of angioplasty. Other imaging techniques include PET scans, which are the gold standard for blood flow measurements. It has an advantage over exercise testing with thallium as it detects jeopardized but viable heart muscle and can identify patients with CAD and severe left ventricular dysfunction that may be candidates for revascularization or transplant. It is very expensive, though, and rarely used. CT scans are predominantly used for identifying masses or detecting aortic aneurysms and pericardial thickening and pericarditis. Single photon emission computed tomography, or SPECT, is used to detect and quantify myocardial perfusion defects and contractility defects. It is used in conjunction with radioactive isotopes and can improve the view of myocardial perfusion studies. Although less accurate than PET scans, it is easier to perform and more available. It can be used with cestamide, a radioactive perfusion agent, to improve views of cardiac perfusion. Electron beam computed tomography, EBCT, is used to detect calcium in the coronary arteries and quantify coronary atherosclerosis. This increased calcification is associated with increased risk of MI and CAD. Lastly, MUGA, MRI, and MRA can also be used to assess cardiac function and blood flow. Multigated acquisition imaging is a non-invasive technique to calculate left ventricular ejection fraction in the critically ill cardiac patient when cardiac catheterization would be dangerous. It consists of injecting a radioactive tracer and collecting images with a gamma camera. It measures multiple individual ejection fractions, knowing the heart rate and RR intervals on the ECG. MRIs have similar diagnostic accuracies to PET scans, but are less expensive and more available, but are used in limited fashion as echocardiography and nuclear scans are more familiar and practiced. They can be used to evaluate heart morphology, blood flow, and contractility, however. Lastly, magnetic resonance angiograms use magnetic and radio waves to take pictures of blood vessels and can be used with contrast to detect aneurysms, dissections, or stenosis of vessels. Patients with metal devices, however, cannot use this diagnostic tool due to its strong magnet similar to an MRI.